Let's see if I can get Robert in. Well, let's talk about how to pay for virtual care. I think we can get started.
All right. Yeah. Go ahead.
No, I was just saying, just historically, in general, the incentive has never really been there to reimburse for something as simple as like a phone call or anything along those lines. I mean, I know the reimbursement for a phone call is only like $6 or $10. So just the incentive historically has been there. And I know there's been some changes.
Yeah, I mean, the problem has really always been that, the fee-for-service payment model really incentivizes in-person care. And so when virtual technologies started gaining interest, then CMS knew that they had to start kind of setting up codes to be able to pay for virtual care stuff. And the thing that really kind of has accelerated the space has been the introduction of chronic care management and remote patient monitoring codes. Those have been sufficiently flexible and sufficiently funded to really kind of encourage the adoption of sort of virtual care type models. The original codes were really just telehealth, which is like what we're doing right now, where you video and audio with a physician, but the reimbursement was lower than in-person visits. So as a physician, it's like, why would I take visits like that if I get paid more to have somebody come into the office? But these new codes really were a higher reimbursement rate. And so they've started to incentivize the use of technologies as a revenue center for some practices. So again, those are the RPM and CCM codes. But during COVID, everything's really changed. They increased payment parity for telehealth and in-person visits. And so during this time, it's been incentivized.
Yeah, but it just goes back to what we were talking about in an earlier show about the system in general has never, like our fee-for-service healthcare system, has really never been incentivized to help doctors and patients. If you think about it, like so far as the doctor-patient relationship is concerned, we can do so much doctoring with just a phone call. I remember being on call in the hospital and receiving phone calls at 2 o'clock in the morning and providing a lot of critical care just over the phone. And it's hard to think that that's not valued in the fee-for-service model. I mean, paying $6 or $10 just for a phone call. I mean, it's no surprise to me that doctors don't give their cell phone numbers out to patients because why should they? The incentive isn't there. I know, like in our world, in the full risk world, we're not concerned about billing. So every patient has their doctor's cell phone number, and the doctors want every patient to have their cell phone number so that when there's an emergency, the patient can just access the doctor. I mean, it's like trying to solve, it goes back to like us trying to solve the problems for 2020 using like 1970s technology. It's like the whole system needs a massive upgrade, right?
Yeah, absolutely. And unfortunately, a lot of things in healthcare, in my experience, really do follow the sort of payment environment. So it usually starts with CMS and Medicare deciding that something is needed in sort of the industry as a whole. Now it's a government, so it takes a bit of time to go through the regulatory process. So as these codes come out and as we learn about them and as they kind of change the parameters around them, it starts to allow the system at the bottom to be able to start using it and implementing them. And so RPM and CCM codes currently are the majority, to answer your question there. They are currently funded by Medicare, paid for by Medicare. Some Medicaid programs, some states cover CCM. RPM is a little bit further behind there. And then commercial payers are kind of the furthest behind. And they do it on kind of a case-by-case basis. But I've been talking to a number of different organizations that are encouraging their commercial payers to adopt RPM in particular. And Virginia during COVID actually just mandated that their commercial payers cover RPM. So they're going to get some experience with it. So it's a kind of a case-by-case basis right now, but there's the expectation is that going forward, everybody will soon adopt this as is kind of the historical trends. Medicare comes out and then other payers kind of follow. But that's under the fee-for-service system, as Faisel's saying. And Faisel, during COVID, fee-for-service has been really bad, right?
Oh, my God, especially for primary care. I mean, so again, just as a reminder to anyone listening, 95% of the country is based on the fee-for-service model. It's a transactional model. It's a billing model, which is completely different than the full risk value-based care model. See, in the full risk value-based care model, provider, especially when we're talking about primary care, they're collecting 85 to 90% of the premium ahead of time. So then the primary care doctor is deciding with how to manage the patients, and the incentive is to keep patients healthier. I mean, with COVID, we've seen there are some cities that have had reductions with patient volumes of up to 70%. So you can imagine already, especially for primary care that was struggling even prior to all of this, they now have 60 to 70% reduction in patient volume. And on top of that, the reimbursement, at least up until recently, and I don't know where the commercial payers are at for telehealth or telemedicine. I know many have adopted, but even the reimbursement has been historically 60 to 70% less than what the in-person reimbursement rates are. Isn't that right?
Yeah, yeah, and there's been a big paradox that's occurred during COVID, where the fee-for-service payment system has really caused facilities to lose a lot of revenue for high revenue procedures like surgical procedures or cardiovascular service lines, and primary care has been hit pretty hard too, because their reimbursement was already squeezed, and now patients aren't coming into the office in person. So it's caused a big financial crisis in the healthcare system. But for value-based clinics and value-based provider organizations that are under value contracts, they're still getting the same amount to take care for their patients. So nothing really changed there. It truly is a superior payment model for actually incentivizing better care to patients and not having issues like a pandemic coming along and healthcare systems who are now having to take care of the overflow in the ICU, but not having the financial resources to do it. It's a big problem. Right. And, let's just take a quick history lesson back to why telehealth kind of came out and what the original constraints were. During the early days, CMS kind of limited some telehealth calls to be for rural areas only, because the value there is improving access to care. And so that's been an area where telehealth has been really important. A lot of times it's been sort of a physical site, or they've started to loosen up some of the restrictions there, but it's really important for people who don't have geographic access to healthcare services. What do you think about that, Faisel? Are you guys in any rural areas?
I just think about where I'm at right now. I mean, I'm as rural as it gets. And to do like this Instagram Live, I'm not concerned about the cost and the same thing to go with any kind of FaceTime or Skype or any kind of video conferencing. We don't think about costs with this type of communication in 2020. But the system, which has never been incentivized I really think the system has never been incentivized for prevention. This system, the fee-for-service system, has been this transactional, episodic, reactive sort of model where you wait for a problem to happen. Again, half of all medical care prior to COVID was delivered in the emergency room setting because the incentive for the system was never for primary care. It was never for prevention. We never prioritized, like if someone got overweight or someone's obese, the priority wasn't there to, oh my God, to treat this as this is an emergency. This can lead to chronic medical conditions like diabetes and hypertension. So I think now with COVID, it's forced the entire system. And I think that the system needed to be forced, especially when you're talking about increasing access to care. I mean, still, right, with this system, about 30 million Americans have had no access to care because of not having health insurance. And in addition to that, there are another 40 to 60 million Americans who are considered underinsured, meaning that they can't afford their copays or deductibles. They have insurance, but what good is it if they can't afford to pay the copays or deductibles? So I feel like this whole COVID situation with healthcare, it's really forcing a lot of the drive that was needed to make the transition out of this fee-for-service system.
Yeah, I think that it's really brought to the forefront a lot of these big issues, and I think that moving forward, the value-based transition is going to be very good for virtual care. Right now, the fee-for-service system incentivizes it, but it really is focused. The focus has always been on the payment space and how to increase revenue and how to do, how to pay for it all. But now with value-based care, it can be more focused on what is the clinical benefit here? And so there has been a lot of studies on these programs, and given that the value-based environment requires that provider organizations develop new clinically effective models of care, it's going to hopefully blossom virtual care into that type of space and incentivize being effective at driving clinical outcomes and actually being preventive for patients.
That's right. It's going to take this to, I mean, when you're looking at how much it costs to treat pneumonia in the emergency room setting, I mean, my pneumonia bill was over $10,000. The insurance ended up paying $6,800 for a treatment that we could provide in the outpatient, the exact treatment we could provide in the outpatient setting for literally between $7 to $10. I mean, it's just absolutely ridiculous because the system is more concerned about the billing code than it is just treating the condition itself. I mean, I'm almost even thinking if you're talking about a transition from fee-for-service to value, to maybe make it that, especially for the hospitals, that, hey, if you're providing some kind of service that could be provided in the outpatient setting, you cannot bill for that same pneumonia for a hemodynamically stable patient who could be managed in the outpatient setting the same as you could for somebody who's actually ill that requires an admission. I mean, I'm thinking that it will need to be apart from the entire system changing it altogether, but some sort of step along the way, if that needed to be, it needed to be along those lines. I see here we've got Hank with a couple comments here. Let's see here.
So Hank, the interesting thing about some models, so when we talk about virtual care, we kind of lump a whole bunch of different types of technologies together. There's remote patient monitoring, there's chronic disease management platforms, there's just general patient engagement platforms, there's telehealth platforms. And so, it is possible to implement during a COVID time. It is more difficult, but given that there is, payment from Medicare in particular, it is very feasible. Because a lot of things can be delivered remotely. So a lot of solutions can be implemented and onboard patients remotely. And Faisel, maybe you want to talk about your experience rolling out a virtual care program in like 6 days in one of your clinics.
I know.
Briefly.
We were forced to have to make the transition pretty quickly from a high touch, high frequency model where we see our patients on a monthly basis at ChenMed. And we had to make the change pretty quick to the virtual care, really for the patient safety as well as our staff's, because of COVID. So we were able to make that switch actually within less than a week. And now, definitely we had taken steps prior to that to allow for that transition to happen. We were preparing to make that transition probably over a period of months, not over a period of days. But when the entire system is incentivized, you can imagine in our world, in my world at ChenMed, our average patient is 72, 74 years old, 5 to 7 chronic medical conditions, all of them on fixed incomes, and all our patients, all our centers are actually in some of the most underserved areas in the cities that we're in. So we had to, because we're incentivized to, right?
Yeah. And I think what we're seeing in the industry moving forward is this, payment change that both of which incentivize now some virtual care models through new codes and through payment parity on the fee-for-service side, and then value-based side, it's, can we actually get clinical benefit out of this? Can we give patients better access to physicians and to care team members instead of going to the emergency department? And can we actually have a more proactive care model here that actually keeps patients from deteriorating or keep them maintaining their existing clinical state? And so if that is the case, which those of us in the space believe that it is based on the current evidence, it just comes down to implementing the programs effectively and doing the things that we know are effective, and continuing to research to see what does work in the space. It's relatively new compared to the entire body of medicine. Medicine's been operating the same way for so long, which we talked about last week. And so, we are still in the phase of trying to figure out what works when it comes down to experimentation and being very careful with implementation. And, but now that the payment environment's favorable, I'm very optimistic and excited to see where things go in the future.
Leveling the paying field.
Leveling the paying field. That's the title of this video now.
Oh, I see here Claire has a question here about virtual care with direct primary care. Is that a potential disruptor? I love all the disruption being caused by the direct primary care doctors. Actually, the studies are showing, or at least what I've been able to see on my own, is that because of the relationship, especially with direct primary care, with that relationship that each doctor has with their patients, their patients actually have reduced visits to the emergency room department, which makes sense. Patients would much rather have their primary care doctor manage them when they're not feeling well than they would a stranger in the emergency room setting.
Yeah, I think,
Well, great.
and to kind of conclude on that space, real last point here from me. I can talk about this forever, but direct primary care, I think, it does attract a group of people that want to be more involved in their healthcare. So they're interested in having a better consumer experience if they're paying for it directly. My concern there is for low income populations and for the Medicaid space. If all primary care starts to shift to a direct primary care model, that kind of may inhibit access for some populations. But the direct primary care contracting with employers is definitely going to encourage virtual care as well, because employers are going to want convenience for their employees. And so that's an interesting space as we go forward as well.
Yeah. I mean, when people are driving by the
Okay.
highway and seeing it's 5 minutes for an emergency room visit, or 10 minutes for emergency room, the incentive is, hey, you know what? If I'm not feeling well, I can just head on over to the emergency room. I see here Hank has put in a comment. Opens up most ages, federal subsidy, low income, increasing capitation, downside risk. We definitely need to increase the downside risk. The incentive needs to be there to prevent unnecessary hospitalizations. I mean, if we had to start anywhere with the healthcare system, it's to reduce the unnecessary burden, and of course, leading after that, the unnecessary hospital admissions. Well, Robert, this has been a lot of fun as usual.
Yeah.
You want to do this again next week?
I think we should. I think one thing that would be really interesting, Vassal, is let's do some myth busting here. Okay. I think we can pretend the Mythbusters is off air, so I feel like we can become the new Mythbusters of virtual care. Maybe we'll talk about common misconceptions about it.
Let's do it. I love it.
All right. Okay.
Okay.
Well, I'll see you next week.
Thank you so much again. This has been great. Yeah, we'll see you. So long. Take care. Bye-bye.